Hey guys, check out this interview with Dr. Hubert Lim of Neuromod Devices. I promise you will not want to miss it. Hey guys, welcome back to the Dr. Cliff Show. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona. And I am joined today by a very special guest, Dr. Hubert Lim from Neuromod and the University of Minnesota. It's very good to have you on the show.
Thank you, Cliff, for having me. It's great to be here.
So do me a quick favor, kind of introduce yourself to the audience. I mentioned that your affiliation with Neuromod and University of Minnesota, fellow Big Ten school, but kind of give everyone an understanding of your background here.
Yeah, so I am a professor of biomedical engineering and also otolaryngology at the University of Minnesota, also serving as the early Bakken medical devices director there. In addition to that, which is relevant for what we're going to talk about today, I am serving as the Chief Scientific Officer of Neuromod Devices. So I serve two hats and working at both places.
Excellent, awesome. So take me actually back to where you grew up.
Yeah, I was born in Cerritos, California. I'm not sure if you...
I know Cerritos actually because I know a Dr. David DeCreek who practices in Cerritos, California. He's an audiologist out there. But yeah, very cool.
Yeah, so I was born there, lived in Buena Park for a little bit, and then moved to Chino Hills.
Chino, okay.
I don't know if you know that.
So
Chino
Chino Hills, I'm trying to think, is that... I could be wrong. Sacramento area?
No, more Southern California.
Southern California still. Okay.
I always say Anaheim, Disneyland, because then people.
Okay, I know that. Yeah,
they know that area. And then I went to UC San Diego for undergrad.
Okay, very good.
But grad school, PhD, pulled me to Michigan.
Okay.
For the Midwest. I mean, not to be biased, but it is probably the best university in the Midwest.
Well, I don't know about that. I think University of Illinois, give you a run for your money there. Yeah. But so what did you study in undergrad?
Yeah, so undergrad was biomedical engineering also, or they at that time called it bioengineering. And a lot of it was, I was still interested in med tech devices. I was always intrigued by the hearing system and how sound is processed in the brain, but I was going more towards metabolic and cardiovascular types of disorders then. It wasn't until grad school where I started to shift towards hearing technologies.
So what was that transition like going from university? Oh, so I believe you did undergrad, California, then graduate school, University of Michigan.
Yeah.
What was that transition like going into that?
Yeah, so a little bit interesting background. I have always been intrigued by how sound is processed in the brain. And I don't know, do you remember Napster?
Oh yeah.
So at UC San Diego, I was intrigued by the time, at the time music was starting to become available, online, and obviously they were providing for free. But the idea was, I was watching how the neural interface community was moving, and brain recordings using electrodes that you put on your scalp, they were starting to see that you could take signals, right? Also invasive and other clinical applications, but taking signals from the scalp and being able to infer what the brain is thinking or trying to do, or even the state of the brain. So at the time, I was very excited to think about using those brain signals to figure out preference, music preference, and whether you appreciate or liked a song or preferred a song. And so my vision and hope was that I could create a device like an EEG, right, a brain recording device, that could determine music preference, and then it would figure out all the songs that were coming online, like Napster, and then direct you.
That's intense.
But at the time, it was like a few places that could probably go, enable that technology. UCLA, there was this previous DARPA program manager, Dr. Jack Judy, who was there, and then Michigan had the Michigan Neural Technologies, and then Utah. So these are the places I was quite interested in, and Michigan was where I applied to do that.
Is that right? Is that right? So Eric, so that took you there to Michigan, and then you must have spent quite a long time there at Michigan.
Yeah, I was there for 6 years, almost 6 years, and yes, I went there for this. At the time, it was going to be called Huphoria, so my name was Hugh, and then the idea was to call it Huphoria, that you would be able to determine those signals. But I will say, during my first year there's a famous institute. It's called Kresge Research, Hearing Research Institute. So I was doing my PhD with Dr. David Anderson, one of the co-inventors of these neural technologies that go into the brain. And he had exposed me to the cochlear implant world, which you're familiar with in the audiology community. And even though I was super excited about these kind of brain signals and using it for music preference, I then started to, see talks on cochlear implants. I went in and saw cochlear implant surgeries, met and observed cochlear implant fittings and patients, and I was just blown away. I mean, it was amazing that you could see individuals who are completely deaf, then they get these technologies, and then they're able, not right away, but over several months, be able to integrate into mainstream society.
It's the closest thing I've seen to a medical miracle ever.
It is a pure miracle, and so that just got me really excited. And I didn't give up my dream, but I shifted my direction to do hearing technology. So that was the catalyst that happened.
So then, how long into your PhD did it take you to transition into that?
Yeah, so that was during my first year.
Okay.
And one of the first projects that cochlear implants, the thing is that there are so many smart people in that field. And I think I'm a hard worker. I don't know, I'll say as smart as all those experts there, but I'm a hard worker, and I figured in cochlear implant field, they've already done a lot of innovative things and successes. So I was looking at, where are the limitations, and at that time, I saw that with cochlear implants, the audience may know, or if not, let me explain, is, you have this electrode technology. So they're just like silicon material that has these metal contacts, and you deliver current through those contacts that then activate your remaining nerve pathway to your brain. But the thing is, that array is actually put into this snail-looking thing called the cochlea, which is great because it houses the array in a secure, stable way, safe way. But the problem is physics 101. You've got to deliver current through the bony wall to the other side to activate the nerve fibers. So you have an interface problem. And even though all this innovation was happening and all these stimulation strategies, sound processing, you name it, the challenge is that you end up getting maybe like 4 to 8 channels of information potentially, right? Whereas when you think about speech and noise, music appreciation, multiple talkers, we need like 50 to 100 channels.
Yeah.
So that's where, for me, I said, okay, where I can make an impact is let's develop something that goes into the brain, into the nerve. So my first project was auditory nerve implant.
Okay.
That was where I was going to pursue that, and I started to work with a really amazing surgeon, Dr. Alex Arts there. There was another fellow there, Dr. Wayne Berryhill, and we started to work on some projects related to that. But I mean, we ran into some challenges, and another project came up where we're going to develop an electrode array to go directly into the brain, so the auditory midbrain.
Oh, I got you.
Yeah.
So different from auditory brainstem implant?
Yeah, different from auditory. So I'm glad you brought that up. I mean, at that time, since 1979, because people who have tumors, acoustic neuromas, and vestibular schwannomas, they basically have to go in and remove the tumor, and at that time, they try to preserve as much as they can the auditory function, but definitely the facial function. So then they remove the tumor. It's usually bilateral, so they become completely deaf because the auditory nerve is compromised, and then they'll place an array on the cochlear nucleus or the brainstem.
Right. I had Matt Hay on the show here, actually. He has an auditory brainstem implant because of his NF2 that took his hearing from both of his ears. So amazing how that stuff works. The fact that you can implant something like that onto the brain is just crazy.
And they do it in children, 8, 9 months old, they're doing that. And I not to say anything bad, it's a miracle also with what the lip reading enhancement and speech cues that it can provide. And for me, the surgery was challenging when I observed it with the surgeons because they have to remove the tumor in that area. And at the time, there were hypotheses that it might be damaging the brainstem.
Yeah.
And so that's where I thought, this was 24 years ago, and in my mind I thought everybody's going to have a brain implant 5 years later. So I thought, why not just go to the brain? They're doing it for Parkinson's tremors, epilepsy, other conditions. So then my PhD shifted fully into a brain implant, put into the inferior colliculus, which is the auditory portion of the midbrain, and restore hearing by increasing the number of channels. And the vision was I'd have like 1,000 electrodes, not too different from Elon Musk's Neuralink.
Yeah, exactly.
And that vision, right? So that's what I pursued for my PhD, auditory nerve implant. I said I'd come back to it. This Euphoria device, I said I'd come back to it. I haven't come back to the first that one, but auditory nerve implant.
Waiting.
I'm actually.
That'll be fun. That'd be fun.
Yeah. So that's where I did my PhD.
Very cool. And so then what was the transition from there, working on that type of research, and then finding yourself at University of Minnesota right now?
Yeah, so there was another stop along the way. I did my PhD in the auditory midbrain implant. At the time, I was trying to figure out midbrain stimulation, and through that also kind of these feedback loops. I'm not sure if you're familiar, but sound goes up and then it has to come back down to optimize the sound you're hearing. And that feedback can come down to the midbrain, thalamus, it go down, from there also to even brainstem and cochlear pathways, right?
Yep.
But during that time, I was intrigued by this auditory midbrain implant. I was just fortunate. It was very lucky of me that I ran into a famous neurosurgeon, Dr. Thomas Lennertz, who was already working with Cochlear, which the leading cochlear implant company, and they were already developing a human prototype device to implant into the inferior colliculus for hearing restoration. We didn't know of each other. You're going to see the theme here. Is working independently, and you discover other people working on, and you join forces. But I met him at a meeting, 2003, and I had already collected some good animal data to show it's feasible. They had a human technology. Again, you're going to see this theme, human technology. And we knew that if we worked together, we could push it to patients very quickly, in a safe and ethical way. So then I finished my PhD, 2005, 2006, packed up my bags, moved to Hanover, Germany.
Okay.
And that's where I got to work with patients, hearing, loss and deafness, deaf patients, but also many of these also had tinnitus.
Yeah. Is that kind of like your first introduction into the world of tinnitus?
It is. I mean, I've been exposed to tinnitus, but I never thought of myself as a tinnitus researcher, and that's where a lot of that started to, brewing in my mind, ideas and so forth.
And so did you come out of Germany and like one of your main focuses was the tinnitus world?
That's right.
Is that how that worked? And then so how long did you actually spend over there in Germany?
So I was there for about 3.5 to 4 years.
Okay.
So 2006 January to 2009 summer.
Okay, I gotcha.
And the main reason was to work on auditory midbrain implant and auditory brainstem implant. But what had happened was that because so many individuals who have hearing loss also have tinnitus, many of these individuals that I was stimulating, because we implant into those brain regions, and as I was trying to fit their devices to restore hearing, many of them had tinnitus, and through serendipity, it wasn't intentional, we didn't get the electrode in the right spots in all the cases. In fact, many of the sites were outside and they were in non-auditory regions. And we happened to stimulate those non-auditory regions. That would also cause paresthesia and body sensations, and those would alter the tinnitus or suppress the tinnitus.
No kidding.
So that was kind of the first, it was like,
So this is kind of like you started figuring this stuff out, kind of like they invented the potato chip, where they accidentally cut the potato too thin and fried it up, right?
Exactly.
So exactly like that.
Yeah.
So that's kind of interesting. So you started noticing that if you were to stimulate different areas of the brain, that you would actually have an impact on the tinnitus. And I think the one thing about tinnitus that everyone's fairly well aware of is that we don't know it exactly at this point. Like where it originates, what's causing it, all of that stuff.
Yeah, and that's the part I think we all have to be humble about, because people ask me, they're like, you're working on this treatment, that treatment, how does it work? What's the mechanism of action? And I will share some of those proposed mechanism of actions, but it is complicated because the brain, the different neurons are all interconnected, so it's hard to know like where is the starting point and where's the end. And so pathways in the brainstem and midbrain and thalamus and cortex, they're all intertwined, and even the auditory system is interconnected with the non-auditory limbic, frontal, cognitive regions as well. So it's hard to really grasp. And when you have tinnitus, I'm a strong believer that most people, if not all, with tinnitus have some form of hearing loss.
Oh yeah.
I would say that just because your audiogram looks, like standard,
normal, right? Yeah.
Then people say, oh, your hearing is fine, but we know that that's not.
Yeah, I mean,
the full
and
story.
I made a video years ago talking about the 3 types of hearing loss, right? So the sensory neural conductive, and then the mixed. And then here, just within the last year, I made a new video talking about hidden hearing loss as well, right? Where you're not able to clinically diagnose it, with the X's and O's on an audiogram, but there's definitely some level of loss there.
Yeah, exactly. So and because of that, I do think there is this loss of input, and the brain tries to compensate for the most part. Not everyone exactly that way. But even how the brain modifies itself, right, when that hearing loss happens, it's hard because it could be that cells in certain brain regions are elevated and firing to compensate, right? But those cells might be connecting to other cells that might shut them down, right? And then you might cause more cells to communicate with each other in ways they're not supposed to, and that might cause perception.
Yeah, unintended consequences kind of thing.
Exactly,
yeah.
And each person might have a little bit of a different variation of
Right.
that. So it gets a bit tricky, and we'll get to this later, but like my thought of trying to shut down that tinnitus, that's what I initially wanted to do, but I realized how hard that is, and kind of reframed my thinking of what is the most practical way right now. I'm not saying it won't happen in the future, to really help a lot of people, with trying to distract the brain away from the tinnitus rather than always focusing, let's shut it off. I mean, ideally that would be the goal, but what's the way we can help people?
Absolutely.
In a practical
So
and
now,
quick way?
2008, 2009, you had started to do some research around this bimodal neuromodulation and different ways of implementing it. And that's kind of like, I think, your introduction right there into this world of bimodal neuromodulation.
Yeah, totally. So at that stage, then what happened, things were brewing in my mind, and I had always, because of my PhD work and the circuits that I was talking about, I am a super fan of the work that Dr. Suga and Dr. Junian and Gunter Ered and many folks, and Dr. Weinberger from, late Weinberger from UC Irvine, they were showing that in many ways you had a frequency organization, and you could basically play sounds, tones, but other features too, and you could electrically stimulate, even the body, but also you could stimulate, and this is what got me most excited, regions in the brain that had feedback loops, auditory or non-auditory. And if you paired them together, you could actually change the frequency sensitivity of these cells, right? And so I'd been tracking that literature. So like, for example, if a neuron was tuned to like 1 kilohertz and it loves 1 kilohertz, you could make it sensitive to 5 kilohertz. Or 3 kilohertz, right? You can basically change its identity, which, like, to me,
in a predictable way.
In a predictable way, right? Wow. You stimulate and you can cause these shifts. But like, I'm sure you're trained in auditory science, like the tonotopy, the frequency organization. That's like fundamental,
right?
But now I'm telling you, it's not fundamental. you could switch it on, and that was like, oh my God, that's amazing. So during my PhDs, I was tracking that. And then in postdoc, when I started to stimulate with these patients, these different regions, and we're modulating and modifying tinnitus, and a lot of them were non-auditory regions and some involved with this loop, that's when I started to think, and I wasn't thinking non-invasive at the time because I was all invasive technologies. I was thinking that we would then have devices that would be implanted in these different brain regions, right? Cortex ideally, because you can actually access the cortex more readily than the stuff I was working on in the midbrain. And then the idea would be for tinnitus patients, you would actually present tones and sounds and use brain stimulation to start shifting things in a systematic way. And actually, that was my interview talk that I gave at University of Minnesota. One of the, I was talking about central auditory prosthetics, and then one was on tinnitus using invasive stim with sounds to kind of shift things around to combat tinnitus, right? So I was already kind of thinking that way, and I gave that interview around 2008.
Yeah.
They liked it, I guess.
Yeah, well, I guess so, apparently.
They hired me, yeah.
But so, let's take a look at that a little bit further. So when a lot of people watching this really are interested in this Lenire device, right? With bimodal neuromodulation, you're doing the auditory input, but you're also doing the tongue stimulation. But there's actually different forms of bimodal neuromodulation. That's right. And one of the studies that you were talking to me about earlier before we started recording was this one where you identified that you can stimulate other areas. It doesn't have to be the tongue with that tactile response or the stimulation, tactile stimulation, but you can actually stimulate other areas as well.
That's right. And again, so the concept is just reinforcement learning, right? And if you step back, over 100 years ago, over a century ago, Pavlov's dog, right? In that case, you have a bell. The brain doesn't care about the bell. The dog doesn't care about the bell. You then serve food to the dog, and the dog will salivate, right? The dog is hungry, wants the food. And then you pair the two together. So in this case, the food is the reinforcer. The bell is meaningless. And then now when you play the bell, the dog lights up, the brain lights up and salivates, right? But it's not only the bell, right? The food makes the dog salivate to the footstep sounds. If you read the paper, the person bringing the food and all things that are related because of the pairing. So it's very broad concept. And then later on, 50 years ago or 50 years after that, Donald Hebb and others showed that in the brain, you actually have things shifting and changing, right? So it shows you it's behavioral, but obviously if it's behavioral, something's got to be changing in the brain. They actually show in the brain that things are becoming more sensitive or not to that pairing. And then I'd say probably like the 70s too, but mostly 80s, 90s, 2000, people started to show that you could do it with tones and other cool features, right? And pairing with the body or, like I said, the invasive stim, and start systematically shifting the coding properties of these cells using paired stimulation. And that's where I got really excited. And when I came to Minnesota, I still believe in invasive. I still pursued that. I'd say about it's sub part of my lab, and I presented at different meetings. I was still doing invasive stim with paired sounds. But at that time, I realized like we need to figure out a way to do it on a broader scale, because implants, as you know, cost high, and not a lot of people will be able to benefit. So that's where then I was interested. Can we do it in a non-invasive way? Body stim preferably would be one way. I won't get into it today, but I also, people are using coils, magnetic coils, to stimulate the brain, or ultrasound fields. So my lab also does that, to look at non-invasive technology to directly activate the brain without implants. But the idea was body stim. And so looking at the literature and looking at all these different studies, it wasn't clear. It looked like, you could simulate most body regions and most reinforcer. I don't know, I've never tried, but visual stim, potentially also as a reinforcer. But we had to do the experiments to figure out what would be, the strongest drivers to pair non-invasively, and that's the research that at Minnesota then I pursued, right?
So what? It was electrical stim, and you just tested it on a variety of different areas throughout, or on the surface of the body, or potentially even internal to the body, which you would consider the tongue stimulation to be that, right?
Yeah. We did invasive, and then there was a main project in my lab that we published on in 2015 in Nature Scientific Reports. We basically we took guinea pigs, animal research, and we stimulated all different body regions. The ear, the cheek, the tongue, the neck, different body regions, limbs, and we basically just wanted to see what site when you pair it with sounds. I mean, we did tones also, but I don't know. I was a strong believer of more bandwidth, like many frequencies, like noise-like stimuli, because I figured if you want to drive things, I mean, that's going to drive a lot of things at once. And so a lot of that paper, if you look at it, is looking at these kind of bandwidth or noise-like stimuli. But it works for tones as well, as we show in my lab with ongoing research. But the idea was to see which body regions, but also what kind of timing patterns and electrical stimulation with sounds would cause these effects. And interestingly, we discovered, two that popped out. Not, they all worked, but the two that I got most excited about and showed strong results was electrical stimulation of the ear with sound, which, I mean, that made sense to me because like the ear, it's all interconnected. But the weird one that popped up was electrical stimulation of the tongue with sound. And we're talking earlier at the time, I was not part of Neuromod Devices.
Right.
I was working to start my own company doing bimodal stimulation, and Ross knows this. They're my enemy, right? My competitor.
Yeah. At the time, though, really.
So then that was where we decided, okay, it's interesting. The tongue is an interesting location, and so we published that in one of the paragraphs of the discussion. Basically, say tongue is a good location to go for. And Ross and his team in Ireland caught hold of the paper and that paragraph, and then reached out to me and just asked, do you want to work together?
And this was back end 2009.
16
oh, sorry,
2016.
Okay.
Yeah. So it published in 2015, and then this was all happened during the 2016-17 time when I actually went to the company.
Gotcha.
Yeah.
Now, some people are going to make this association with you coming from University of Michigan.
Yeah.
Dr. Susan Shore. I think the Michigan Tinnitus device.
Yeah.
So what are the differences then between, using this, tongue stimulation and then what she's doing with that device?
Yeah, so I've known Dr. Susan Shore for many, many years. And there are differences in the way it's implemented. Her device, they're doing electrical stimulation of the cheek or neck region. They also, I don't know the software exactly that they use and how it does it, but somehow it looks like it's sounds that are very similar to the tinnitus. And the main concept is just trying to find an optimal delay, right, that will be presented to an individual that can then shut down the tinnitus sound, right? So that's what they're proposing. Yeah. And there could be some different pathways or mechanism that's going on. For me, I just take a broader view of how this all works. If I just kind of make it very simple, based on the Pavlov's dog condition, I'm not really trying to find out how to shut down the tinnitus directly, right? The concept is pretty straightforward. Let's say your tinnitus is like 8 kilohertz. I could present 2 kilohertz, and you'll shift a little bit because you might be like, why am I hearing 2 kilohertz? But it's not really going to be that meaningful to you, right? But imagine I play 2 kilohertz and then I electrically stimulate your tongue, or I have a reinforcer. Then your brain's like, okay, that's weird. I'm getting 2 kilohertz, my tongue's being stimulated. I probably should be paying attention because this is not like typical, right? Now, you could do that over and over again, but I would hypothesize you'd create tinnitus, right? Or at least some temporary tinnitus, or if you had tinnitus, may exacerbate at that region. But instead now, you go to 4 kilohertz. You go to 12 kilohertz.
And you just shift it around.
You shift it around, ideally away from your tinnitus sound, right? And if you have more like noise-like, for the most part, you could probably find a centroid of energy of where the tinnitus, and you'd want to stay away from that. That's the ideal way, right, that you would do tinnitus treatment. So over time, the idea is that your brain would start to shift away from the tinnitus sound because it is being forced to pay attention to all these other sounds. And we already know from those physiology studies that when your brain starts to become sensitive to other sounds, it cannot be sensitive to everything. So it does indirectly then dilute its attention or activity to the tinnitus sound. That's pretty much the concept.
It's pretty interesting. The thing that's exciting about it is that, bimodal neuromodulation is being worked on by different people, and they're both seeing benefit from it.
Yeah.
Which is the cool thing, because, it's not like you guys are working directly together and you're almost like forcing it to be like, this is going to be the option. It's like separate people at separate places that are not working together are kind of discovering the similar type of an effect. Yeah,
I think that's the important thing, because I know people are associating me and Neuromod devices because I'm working there. And Susan Shore, I was at University of Michigan, so I think a lot of people are getting confused about the interrelationships. Susan Shore had her lab and she was doing things. I have my lab, I was doing things, and Neuromod had, their work, right? And there's a couple other groups doing bimodal, even in Europe and so forth, right? But we're all working independent of each other. It was a lot of just different approaches, different thought processes. But in the end of the day, you're seeing the studies coming out.
Yeah.
I had the animal results. Neuromod had their results early on. Dr. Susan Shore had her results. But they're all pointing towards this efficacy that's coming out, right?
So Neuromod devices, they reach out to you after you had written this and discovered this in your paper.
Yeah.
What was the progression? Because I know that, was it 2018 that you were announced the chief scientific officer?
2017, they made the formal announcement. Yeah.
So they brought you on board at that point in time as the chief scientific officer. And so then, what was Neuromod working up until that point?
Yeah, so they had run some critical pilot studies at the time, and they already had CE mark, right? So they were briefly on the market in Europe, and then they were trying to build their scientific understanding and clinical data to really understand what's the best way to implement the treatment, right? Now, since my research was a lot about fine-tuning and trying to figure out the best way to activate in animals at the time, right? And I'd done a few pilot studies, in a few individuals. And actually, what's interesting is I ran a pilot study at Minnesota, And there were individuals who were going on blogs describing their experience, and some of them had some really good results. And so I know there's some people talking about, like, you know, doing the Minnesota way or the Michigan way or the Neuromod way. But I will tell you, we're all trying to incorporate, you know, the best we can, the different features to give the most, you know, benefit possible. But at the time then, the question was, let's go through a clinically rigorous process to figure out what are the best, or at least best within the time constraints and financial constraints, the best features we could implement for the most people, right? And that's not easy because, you know, you've got different sound features, you got different tongue features, and you've got different delays, and how do you all implement this together? And so when I came on board, you know, I was very excited because as an academic, you might get lucky and be able to run large-scale studies and, you know, try these different settings and so forth. But you'll see a lot of, and I think you know this in the hearing world, you'll see a lot of studies with like 15 patients or 10 or 20. When I was considering to go to Neuromod, the board there and the investor and so forth, they all said, look, we get you. Like, go for these large-scale studies. Like, make some sense out of it, and, you know, people will be able to see the data, or we will be able to see the data, and we'll be able to make more sense about what's going on, right? And that was the idea. And the whole plan was we're going to do a series of large-scale studies leading to our confirmatory clinical trial and FDA approval, right?
Yeah, so let's talk about the Lenire device here briefly, and then I would like to get into those trials that you guys have done, because they're very interesting. And so obviously we have the auditory stimulus, and we're talking bimodal neuromodulation, bimodal meaning we need two forms of stimulus, right? So we have our auditory stimulus that's played by this, and then we have our controller and our tongue tip. So you would actually be having this inside your mouth. This is all set up by the audiologist, essentially, who's working with you as a patient. And then you find, is it 1 or 2 times a day that you're actually utilizing this, where you're listening to the sounds, you're getting your tongue stimulated by this, and kind of like you were talking about before, is that you're just trying to almost like reprogram the brain away from this tinnitus perception, right?
Correct.
And so then, is that a fairly good explanation? How would you describe it?
Oh, that's a great explanation. You know, some things to think about here is, you know, the sound itself, when you put it on, and, you know, obviously we could share sound clips for your audience. There's going to be some rich sounds in there, right? There's going to be some tones. There is options to kind of turn off or dampen the background musical noise, but you have that component in there. And then this electrode here, it's hard for the audience to, I don't know, do I?
Yeah, they'll zoom in on it.
They'll zoom in on it, okay. I mean, there's 32 electrodes on here. And the idea, the thing about if you really believe neuroplasticity, right? Like, your brain gets bored. I mean, if you try to learn things and it's the same boring thing, it's very hard, you know, to keep your brain active in that way. So the idea is to keep a bit of novelty in there. And so it is stimulating different locations on your tongue, and it's paired with different tones and sounds that are being presented. There's different ways you could do it. You can synchronize them, you can have some delays and so forth. So there are some different settings that we looked at, and the idea then is that they would do it 30 minutes. You know, you could. We asked that they use it for at least 36 hours over 12 weeks. That's the minimum compliance. That's based on, you know, prior pilot data, but recommended 2 sessions per day, and they can do them in the same, you know, sequential way in one sitting, or they can break them up, right? 1 30-minute session here, 1 30-minute, you know, session there. So that's the general idea. And you know, as I mentioned before, we use this approach of, you know, pairing with sounds. Now, ideally, we'd want to not play your tinnitus sound because that would then reinforce your tinnitus. But how we actually optimize per individual, this is something we could talk about at the end of this session, or, you know, our discussion. But it will take some creativity on how we get there. Yeah. So this is more of a, think of it as in a first version, one size fits all kind of device. So it's not going to be for everyone, but it does include a broad range of sounds that we hope most are not.
Well, I mean, you say it's not going to be perfect for everyone, but I mean, the clinical trial data is pretty compelling that it works for a lot of people, right? Yeah. So, you know, when did the actual TENS A1 clinical trial, when was that one conducted?
Yeah, so that was, it finished up, so it was right when I got there. It was ramping up, and it basically finished in 2017. Well, we had 12 months follow-up, so 2017-18 time. And then we then followed it up with another clinical trial soon after, 2019-20 time. So that was kind of the time frame. And then our FDA study was 2022.
Okay.
So we had these three studies that came about.
So I want to, and I can put this up as an infographic for you guys, but so this particular clinical trial had the 10A1, I should say, clinical trial had 326 participants. And some of the key data that came out of that, so 12 weeks of treatment, so everyone went through the same 12 weeks of treatment, and then they actually did a measure 12 months after the conclusion of the direct treatments, right, to see, was there a long-lasting benefit from this. And so basically what it indicated is that 86.2% of treatment compliant participants demonstrated an improvement in tinnitus symptoms and severity when evaluated after 12 weeks of treatment. So that's great. So during the treatment window, like right immediately after it, a huge percentage, almost ridiculously high percentage of individuals showed a positive impact on their tinnitus.
That's right.
The next key point here is 80.1% of treatment compliant participants experienced continued improvement in tinnitus symptom severity when evaluated at 12 months post-treatment, which I don't know if I've ever seen anything like this at all for any other, I mean, you can't stop working out after 12 weeks and then have the same, physique that you would have a year later. Wouldn't that be great?
Yeah.
But you can't do that, and they were seeing that with this Tent-1A trial. And then the last one here is the 77.8% of participants, when asked at their final visit, said they would recommend the Lenire treatment to others with tinnitus. So a lot of these individuals are like, yes, this worked for me. I would recommend this to my friends. So, for those individuals out there who don't understand this clinical trial process, we talked about it briefly before we started recording. Can you kind of explain like the progression here of going from A1 to A2 to A3?
Yeah. Thank you for sharing that, and I'll put some clarity on it here. So, as I mentioned, there's a lot of settings that we have to do, and I've been in multiple talks and interviews and podcasts, and I try to do it's very complicated, but I'll try to make it more simplified. In the end of the day, we're not sure yet what stim settings are effective, so we need to explore that space and look at how different settings are driving the therapeutic outcomes. The challenge we face is that you could have like 100 different settings, right? But then you don't want to run a study with 100 different settings and 5 participants in each setting, right? And you see that happen in the science clinical world, right? Because they're trying to explore. So what we did was we decided, we still need large numbers, and I'm talking like each group having 100 participants, right? So a lot of data. And the idea behind that, and Neuromod, kudos, that they're pushing this forward at the time, let's take different settings that have multiple features, right? So they're bundled, okay? They're bundled settings. So there's 3 of them in 10A1, okay? Setting 1, arm 1, setting 2, arm 2, setting 3, arm 3, right? And they're gonna have different features. But the idea then is you can look at those arms and see what happens, and then from there figure out for the next study what would be a good set of settings. And ideally what you would do is you take those bundled settings and unbundle them, right? You would then figure out, okay, these features seem to matter, these features not so much, so then now let's run another study to unbundle things and try to isolate. So 10A2, which we'll get to, that was the idea, is that let's separate things out and figure out how they're contributing.
So that was a little bit more refined. You're starting to control the variables a little bit more when it comes to that.
Exactly. And then 10A3, which is what we worked closely with guidance from FDA, was then to just break it down to the bare minimum and see what happens with this, and then you add in this and see what happens, right? That was our confirmatory controlled clinical trial.
Gotcha.
Right? So that was the progression.
And it took several years, obviously, to progress through this, right? Easy for me to say. I didn't participate at all in these, but so let's go on to then, now that we kind of have a general understanding of the purpose of these, let's go to the tent.
I will say one other thing, because I know the audience always asks, controlled clinical trial, right? And this is where I hope I can be clear here for the audiences. There are different kinds of study designs, right? I mean, I wouldn't say it's the gold standard. People will say the randomized controlled trial, placebo-controlled, right? It's one type of rigorous clinical trial. You have a stimulation condition, or you have a drug that's an active drug, and then you have something that's like the fake, right?
Right.
The sham control. And the idea is that everything's blinded, and then you look at what happens, and you're trying to look at the placebo effect, right?
Right.
Really what's going on.
And the person who's taking the placebo, the sugar pill, has no clue. There's no way for them to know that they're taking the sham.
That's the ideal, right? Yeah. But then there's also a lot of situations where you can't blind, right? In my field, neuromodulation field, especially for wearable technologies, you can't blind. And even like cognitive behavioral therapy, they can't blind, because they'll say that we're comparing it to a standard of care, right? And so they may say that they've done a rigorous clinical trial, but you won't say, oh, they didn't do a good job because they couldn't blind it. You can't blind those behavioral approaches, right? So you have to kind of think creatively of how you design. So a different type of design is what's called an active control design. And that's more similar to like dosage studies and drug studies, right?
So like everyone's getting it, they know they're getting it, they're just getting different dosages of it.
Yeah, and you can't tell then, it's blinded, right? And so these are some things to kind of think about when you're designing. It's not just one design for every study. Each study has its variant, and you got to think about the pros and cons, right? So with Neuromod devices, I even knew Neuromod, what was going on. They had already been CE marked, they had already been out. So studies in Europe, especially in Ireland, I wouldn't say everybody, right? But there's a subset of people who are, aware of bimodal stim,
right.
And it is, individuals who get a hold of this, they all know you can feel the tongue stim, you can hear the sounds, right? So you could try to use, the seat to say, oh, you're getting the stim, but you can't feel it, right?
Right.
But in the neuromod field, neuromodulation field, we do things like that with TDCS, the current on the scalp, and you kind of try to trick them. You turn it on a little bit, and you turn it off, and they're like, no, it's in your head. You are getting it. You just don't know you're getting it. And people are like, no, I'm not getting it.
Well, that raises concerns too when you're evaluating the data, right?
Yeah, exactly. And so you have to kind of weigh those out. And now with social media, it makes it much more challenging to do sham control conditions, especially if you already run a study or you've already been out there, and you're always wondering like how much information is going to get out and how much it's going to compromise your study that you work so hard to set up. So sham control condition isn't necessarily always the best way to go.
Right.
Like you have your other.
But there are people who will say like, if you don't have that, I don't believe anything that you tell me.
Yeah, and that's where I think it's just being more, educating and being more aware that there are different situations. And so that all I'm saying is that with our 10A1, 10A2, and 10A3 studies, we took that seriously. We were, thinking about the best ways. And so 10A1, there were a few goals. One is you can't blind it. So we need to use an active control condition, and we wanted to figure out what settings are effective. So at that stage, it wouldn't make sense to put 100 participants in a sham or a fake condition when we're trying to figure out what we're trying to do.
You don't even know what you're looking at yet. Yeah, exactly.
So I'm just trying to put it in perspective, and so that's the idea. And then of course, you get more refined, and then we figure out what's the best way, and then that's where the control happens. So that's the idea. And of course, ideally in active control, you want to show that you have significant differences between arms. Right. That would be the holy grail, right? You make active control. You have two different doses, and you show significant differences. To me, that's even a more rigorous design and outcome than a sham control, because you have to show that you're better than stim that's already happening, and you're fully blinded, right?
Yeah.
And that would be the case. But now, of course, we didn't hit our between arm significance in 10A1 and 10A2, and we had to make a proper design for 10A3, and so that's a fair point.
And at that point, though, you knew what you were looking for and all of that, right? So let's get into the 10A2 clinical trial. So this was 191 participants, so much more than the 10 to 15 that we typically see in the world of hearing care, but nevertheless, so again, same treatment here. Start of treatment to end of treatment was 12 weeks, and then measured again 12 months after. 95% of treatment-compliant participants demonstrated an improvement in tinnitus symptom severity when evaluated after 12 12 weeks of treatment. So to my knowledge, this was even higher than the 10A1. So had more people of those individuals experience a benefit. Then 91% of treatment-compliant participants experienced continued improvements in tinnitus symptom severity when evaluated at 12 months post-treatment. So that's in comparison to 80.1% from the 10A1. And then let's see how close these are. So an extra 10% of individuals, when asked at their final visit, said that they would recommend Lenire treatment to others with tinnitus. So that was 87.8 versus the 77.8 from the TENS-A1 clinical trial. So it seems, and I don't know, did the treatment differ on this one? Or, I mean, what led to these higher percentages?
Yeah, so I'll put that in context too. So from 10A1, we had those 3 settings, bimodal stim settings. And arm 1 had tones, some background musical noise, synchronized to tongue stim. And arm 2 had, similar to that, you couldn't really, you can't tell the difference, but you had delays and some asynchrony going on. And then arm 3 had some different ranges of tones and longer delays, right? So all 3 of those arms, they had, background sounds too. And in there we saw, I'd say that for statistical sense, they were all equivalent, okay?
Okay.
Arm 1 showed a bit better than arm 3, right? And so synchronized, we still believe it has potential to be more potent than arm 3. And on the long-term scale, even though it was post-hoc analysis, so I'm cautious to say it was significant because it was analysis that we did after the study was run, and it's not pre-specified, right? Because that's something in clinical trials you want to do is pre-specify your endpoints. But we saw longer-term better effects with the first condition, right? Now, what was interesting in that study is within the first 6 weeks, we saw most of the improvement happening. And then during the second 6 weeks, there was this plateau effect, right? And then it sustained out. So that was interesting to us because something was not additionally improving as you keep using the treatment. And we see this also with sound therapy, with other conditions.
So actually, hit a ceiling effect of
you've
maximized everything.
That's what we're thinking, right? If it was neuroplasticity. And on top of that, we didn't see a significant difference between arms. And from my animal research, I was wrong, but the idea was that noise was really driving the effect, right? That's the critical feature. And all 3 arms had noise background noise. So 10A2 was designed to try to break that ceiling, or we'll call it the plateau effect, right? By changing things up midway. And we wanted to see if we remove the background stuff and just leave tones with tongue stim, if that was less effective, right? So that's how we designed 10A2. There's 2 arms. Again, we have to put enough participants in each arm, so that those are pretty, large, 80 or so, right? But then we had 2 additional arms because we just wanted to pilot a few things that wasn't going to affect our primary endpoint analysis.
Gotcha.
And from that, what we discovered were a few interesting things, right? To your question that you had, initially, is that when we change things up midway, and what's interesting is in the first arm, they can't perceive these changes, right? We were able to increase about 40% more improvement, right, in their tinnitus. So in 10A1, we had something, I can't remember exactly, 14 points.
Okay.
And in 10A2, we had about 19 points improvement, right? So you had an additional boost, right? And they can't perceive this difference, right? So they're using it, things are changing, and then they get this improvement, right? And the other thing which was interesting was we took out the noise component. So arm 1 had everything. Arm 2 didn't have the noise components, just had tones and tongue. And we did see a little bit less, improvement with arm 2, but it wasn't statistically significant, right? So in that case, we couldn't conclude. What we could conclude is that tongue and tones are needed.
Right.
Noise aren't critical, right? And that if you change things up and keep the brain going, you can get additional improvements. So at 10A2, that's where we were, right? And just to put a few clarifications, the percentages you cited are, and if the audience is interested, the papers, we include all the data, right? They're in scatter plots, and you can see what's going on, especially 10A1. We have, circles that represent all the participants and their scores, so you can look at that. But the idea, from there was we looked at a few things. One was using a standard questionnaire, which you know because there's no objective measure for tinnitus.
And you guys use THI for that?
THI, and we use TFI. And just for the audience, tinnitus handicap inventory and tinnitus functional index, 0 to 100. 0 means no issue. 100 means the worst it can be, catastrophic tinnitus. And so 0 to 100 is a scale. We use THI and TFI, right? And based on that, we could see before treatment and after treatment how much change you have. And so this percentage you're giving are if there was improvement in that THI score, right? Now, there's always questions about how much improvement is going to be clinically meaningful for the patient. And the cited ones are 7 points for THI and 13 points for TFI.
Okay.
And we thought about this in the design. We were hesitant to use these MCID, these clinically significant values. Not that they were against them, but we just thought, because this is exploratory, let's just see what the data looks like.
Right.
And we will report all the data and the changes and be fully transparent and put all the data. Actually, it was Dr. Rich Tyler, who he was like, put all the data in scatter plots. So
there you go.
Okay, there you go. And so the idea then from there was, what percentage were those changes? But instead of trying to get into all these kind of MCID or margins, we just asked the patients, did you benefit? And from there, you see that it was 70% roughly for 10A2.
So for 10A2, so when we talk about this, 95% of treatment compliant participants demonstrated an improvement in tinnitus symptom severity when evaluated after the 12 weeks. Was that any amount of improvement, or was that let's just say that it was just a self-reported improvement, it's not a questionnaire-based question or anything like that. I'm like, yes, I did, or no, I didn't.
Exactly.
Right?
Exactly.
And then when you go and you look at the data further, what percentage of the individuals was it that had the, let's just say using the THI, the clinically significant effect size to say that there was an improvement?
Yeah, so interestingly, for our first 10A1 paper, which was published in Science Translational Medicine, there was an editor commentary that was sent by a group at Cambridge, and they had asked some of those questions. So we officially summarized that data. That's also available online if people are interested. And in 10A2, we calculated too, but we found about 2/3. So roughly 2/3, right? Say they benefited, and if you use those MCIDs, it's like 7 points. In THI, we get about 2/3. So and I won't reveal too much, but the real world data is turning out to be very exciting.
Yeah.
And those benefit questions and the THI are also lining up.
I'm sure that we're waiting for just the right time to release the clinical data. I know Dr. Craig Casper really well, and the stuff that he's been finding out from actually clinically treating patients with Lenire has been remarkable.
Yeah.
So that's really exciting to see. But that really, the ability to start collecting that clinical data here in the United States didn't happen until after the 10A3 study, right? Because this was essentially what led to the FDA de novo approval of this device here in the United States. But if I share some information from this one was done with 204 participants. Over the entire trial, 79.4% of them experienced clinically significant improvement. 82.4% were compliant to the bimodal treatment, which is good because you got to have compliance here. If someone's going to go through this treatment and not be compliant with this is how you have to implement it and how you have to do it, the chances of you getting a positive response are likely going to be lower, of course. And then at the end of it, nearly 90%, so 88.6% responded they would recommend Lenire as a tinnitus treatment, which is really, really high. I mean, I would say that's probably competitive with people who have success with hearing aids, that they're going to be like, absolutely, you should go get hearing aids. So it's impressive data, and this, of course, led to that FDA de novo approval.
Exactly. And I apologize. I want to give a little bit more details about 10A3 for the audience. We hope in a few weeks it'll be published.
Okay, I was actually I've been keeping a lookout online to see when this is going to get published.
It's very close. It goes through a rigorous process and it takes time, but that data will be published soon. And you've already mentioned some of the key results. It's pretty consistent, 10A1, 10A2, 10A3. And just to give people context of 10A3, at least for the results side, you've already mentioned some of that, quite consistent with 10A2 and 10A1. But let me talk about the design of 10A3 so the audience can understand. In 10A2, we had arm 1 and arm 2 where, we showed that tongue and tone stimulation are critical, right? In arm 4 of that study, which you can look at too, we had just presented for the first half, and this is only about 15, it was 15 participants, we just played tones, right? Only tones. Because again, the whole concept, bundled settings and then unbundle the settings and see what happens. So we had arm 4 of that study was just tones, and then we added the tongue component after, right? And we want to see what happens when you add the tongue component. And in there we showed clinically significant improvements, even with that small number of participants, by adding the tongue component to sound, right? So what happened was when we had talked to FDA, who I know there's a lot of viewpoints about FDA, but they were very collaborative and very supportive to work with. And there's a lot of great people in our ENT branch of FDA, and they're also trying to work with you to figure out the most rigorous and fair design, right? And considering all the circumstances. So they, we chatted about the blinding situation.
Right.
We chatted about how to design a proper study. And, if I had my choice, I would love to have done a sham control, use some kind of, deceit or whatever to see how we can, help the individual believe that they're having the treatment, right? And then we do our condition, because then does our bimodal work relative to placebo effect, right? That would be the lower bar, right? Because then you're just looking at placebo. What happened with our discussions and the way, because it can't be blinded, then it was, well, let's see if the tongue component added to the sound part gives you additional clinical benefit, right? And in that case, then the ideal scenario, if you could blind it, would be bimodal stim, tongue and tones, compared to tones alone, right? And I would have taken that also, because then you're doing a head-to-head comparison, but you couldn't blind it, right? But we didn't get to do that one. What we did instead, and what was the higher bar that FDA requested was, well, since you can't blind, what we're going to do is, it makes sense to do sound first, right? Just like we did in arm 4, sound first, and then you basically have all the effects that are going to happen to the sound component, any kind of placebo or things, through the study. And then after that has happened, we add the tongue component and see what happens in the second stage. So 6 weeks of sound.
So 6 and 6.
6 and 6, right? And what we have to show then is that the effects we get are clinically significantly more, right, than what happened to sound only, but on top of what already happened during the first 6 weeks, right? So we have to show more than a doubling of improvement over time.
Because you could theoretically have improvement with just sound alone, right?
Yeah.
And so now you've gotten improvement already. Now you're going to see, like, are we just enhancing above that? And you have to. You have to be able to enhance above that.
You have to. So it's just like increasing slope of improvement, right? So that was a high bar. And it makes sense to me, right? When we talked to FDA and we came up with that discussion, so we had to demonstrate that additional benefit, right? So I thought in the end, I mean, it was a challenging design, but in the end, I thought it was fair. And FDA, it was a great experience working with them. And in the end, it all worked out.
Well, fortunately, because otherwise we probably wouldn't be sitting here. So it's interesting because I think there's also a lot of people out there who they kind of look at the FDA and they're like, oh, the FDA is just going to approve anything, right? And speaking with as many people as I've spoken to who've been working with the Lenire devices, mostly audiologists, right? They said that, like, it's not a shoo-in. Like, you're not guaranteed to get this de novo approval from the FDA. It's like you mentioned yourself, it's a pretty rigorous process.
It is,
And whereas you might want to go a certain direction because you think that would be maybe an easier route to show what you want to show, they're like, no, like, we need to see this instead if we're going to be approving this, right?
Yeah, and that's something for the audience too to understand is FDA has what's called a 510K pathway. And that means that there is something already, out in the market or FDA approved that you could show equivalency to, right? And then the bar there is lower. With de novo, you're creating a whole new category. And so it's not something you take lightly and just be like, okay, we're going to approve it. And I know there's been some discussions and talks. Yes, in Europe previously, CE mark, it was heavily on safety, right? For a de novo approval, you need to demonstrate safety and efficacy. You need to, and there is a ratio of benefit to risk that you have to show, but it's still a very rigorous process. It's not like you go in and you demonstrate safety and no efficacy and you get approval, right? So that is something that FDA takes these things seriously.
Well, I think what Neuromod basically did is made it easier for anyone else who wants to introduce bimodal neuromodulation to the United States market.
It's correct.
So essentially, the hard work was done up front by you guys for this. But let's talk a little bit about rolling this out into the United States market, because for people who are unaware, this has existed, like you had said, in Europe for a period of time. It was not here in the United States, and it's been, I would say, a little over a year now that we've had it available, and actually, we're going through almost kind of like validation of it here in the United States market. So can you kind of walk us through kind of that process?
Yeah, so right now, and I should have said this with the FDA study. In that study, we discovered and learned several things, right? One is that the device is not working for everyone. It's actually labeled for those who have moderate or more severe tinnitus. What we found in this study is that you got clinically significant improvements in your tinnitus with bimodal stim compared to the sound-only stimulation based on the design for those who are moderate and more severe. So the labeling is for that. I know providers may be fitting it for those who are less than on the THI score of 38 points, that's the cutoff, but it's labeled for 38 and above. So when we have it in the US, it is specifically for that group. And then in terms of rollout, this is not my expertise. We have an impressive U.S. team, and their job is to meet with and support the providers, and then provide them with the proper training. There's extensive training, right, to help make sure that they understand all the things we've seen in the clinical trials, what to expect, how to handle different situations, and then be able to support the patients through this journey of using Lenire. And so that's kind of the current state, right?
Yeah. So and I've interviewed a number of those individuals here on the show, and we were just talking about Dr. Craig Casper about having really good results here.
Yeah.
I've actually had both hearing care professionals, I don't know, depending on the different country, if they're called audiologists or if they have the credentials for audiology, but who reached out to me and said that they did not have good responses with the Lenire device overseas. And honestly, at the time, I was so new to this that I'm like, well, I don't really know one way or the other. All I've seen is favorable clinical trial data. So what's potentially leading to maybe not having positive outcomes for certain groups of people?
Yeah, so it's a good question. I don't know these other providers or clinicians that you're referring to. Again, for me, the data I've seen, in totality, right? In Europe also, I work closely with some partners in Europe. There was a paper that was published by Hanover Medical School. They were getting consistent results with the clinical trial, results at the time, 10A1 and 10A2. There's multiple groups across Europe that are getting, actually I'll even say maybe even a bit better than what's in our clinical trials. So it's hard to say what may be caused there. Also numbers, how many are they seeing and what's the percentages, right? But the point is it's not for everyone. So it could be that some clinics, just by chance they had a higher percentage of individuals who this is just not working for, and then in that sense, they believe that it's not working, and they move on, right?
Yeah, totally understand.
Now, I think it's important how many numbers they have too.
Yeah, totally. I think of it with hearing aids too. Someone, you could look at them and you're like, you're a perfect candidate for hearing aids, and they come and get treatment, and it's a disaster. It doesn't work for them for whatever reason, right? Doesn't mean that hearing aids don't work, right? In fact, hearing aids massively work for a lot of people, and it appears as though if everything that we've seen so far, both from a clinical trial perspective and from an actual in-clinic perspective, it seems as though this is probably one of the most effective tinnitus treatments, in my opinion, since hearing aids, that is just used to replace missing sound to affect that mechanism of where tinnitus is being generated in the brain. So,
yeah, and I think that the important thing is, as scientists in the clinical community, so we'll agree, is there's going to be individual patients, right, who are going to have great experiences. There's going to be individual patients who are not going to have good experience. There's going to be providers who may have a certain number of patients coming through, and they may just have a higher percentage that aren't benefiting. So in their mind, this is not working for them. And these things will happen.
Well, you also have to consider candidacy too, right?
Yep.
I mean, you have someone with a really low adverse reaction to their tinnitus, a very low THI, for instance, tinnitus handicap inventory. The chances of them getting is big of a benefit from a Lenire device is lower than someone who has a massively high THI score.
Sure. So some of that could also play a role, and we saw in our clinical trial, the 10A3, that is true, right? That can contribute. But I think what's going to be most important is just as more and more patients are getting Lenire, right? Building the number of people that have experienced it and then looking at what's happening, right? And that's why it's important. It's great you had Emily here and Jason and Craig and others. They're out, treating patients. And so, Emily, I think, has more than 200 now.
It's
Craig
crazy.
must have over 100.
She's all over the place.
Yeah.
She's going down to different states, flying in, treating people on the weekend. It's the level of commitment there to figure this out is amazing.
Yeah, and so time will tell. I mean, so far the data that I've seen across these different groups, and they're working to publish the results. They are supporting the percentages in the clinical trials, right? And so you have to look at numbers. I think we have to be careful to start, one off here, one off there, and try to make too strong of conclusions. It's got to be in totality, what are the numbers? And that's going to be what's convincing.
Yeah.
So when we have over 1,000 individuals in the real world, and you look at the percentages in totality, not this clinic, this patient, that region, then you look at that totality, then I think it's fair to make strong statements about the effectiveness. And so far, obviously with hundreds, it's looking quite consistent with the clinical trials.
I spend a lot of time in the world of social media, of course, just given my chosen career path. But I spend some time in some different tinnitus forums. I publish content on tinnitus. Dr. Rachel Cook on the Dr. Cliff channel publishes content about tinnitus, and we get people on there who have come on and said, the Lenire device is the most amazing thing. I literally used it one time and I feel like I don't even have tinnitus anymore. To the other extreme, which is I've used it as prescribed for the 12 weeks, no change whatsoever, total waste of money, right?
Yeah.
And a lot of the forums that are out there with the tinnitus forums, I would say, and we all know that people who don't have a good response with anything, they're going to be the first ones to vocally say it. So, anytime someone inquires about the Lenire tinnitus treatment device, there's always a bunch of people to jump on there and say, I heard it didn't work, right? So there's a lot of negative, and that's why I like doing these interviews, is to kind of share, all the sides of it. I mean, I would love to have someone on here that it didn't work for, to see kind of what their experience was with that. But like I said, no treatment works for everybody.
That's right.
Literally in the entire world. I mean, is there any treatment that maybe the polio vaccine, right? But now I guess that's making a comeback, so who knows? But it's just kind of interesting to see, and I appreciate all the work that has gone into this, because a lot of people also say that, well, no one's working on this. No one's working on solving the tinnitus problem, and I feel like a lot of people are working on it and spending literally their entire careers trying to find a solution to this problem.
There's a lot of smart and humble and caring people who are working on tinnitus. I won't say that there's a significant amount of funds coming into tinnitus research like you have for other health conditions, considering, which is pretty surprising considering you have over 10% prevalence, whereas other conditions have like 1 to 2%, and they get like order of magnitude more funds invested in it. But there are a lot of people who are working hard on this topic. One of the things that I hope is that there is a kind of positive collaborative spirit, right, of pushing treatments forward. I know it's tough because there's a lot of things out there, and that's why your station is so important in bringing clarity to all the different approaches and what's really going on and how many people are benefiting. But it is sometimes hard because there are these very polarized or extreme comments that are coming out, and it's hard for someone to really see what's going on there. And that's why I think it's important. Peer-reviewed publications. We're working hard. I wish we could make them come out faster, but there is a process that has to go through. But I do think 10A3 will come out, hopefully soon. And there are a few real-world studies with hundreds of participants or patients, sorry, that will be coming out, and then the audience can decide for themselves.
I would say this, like, we have to be careful with this whole idea of confirmation bias, which is like, even if you're reading these studies, if you come into it with the preconception of like, this is what you want to get from that study, that's what you're probably going to get. So if you're like, this just doesn't work, I heard 4 people tell me it doesn't work, now I'm going to go read this study, and I'm going to read it in the way that makes me believe that, like, oh, I can't believe what I'm reading right now.
And that's why I do feel, and we've myself and others and the co-authors as well, we've tried to be as transparent as possible. We've written protocol papers, we've published the papers. If you look at 10A1, I mean, we've included all participants, all the data. So you can see what their scores are, their circles, in there. And we also, present the changes in THI and TFI and what's happening in different situations. And so that's where people, everyone should have the right, they go to the data and they can look at it and make their interpretations, right? And I think that's
again,
the process.
Careful not to come in with the confirmation bias of like, oh, this is it. This is like the only thing. And then that can skew your perception as well. But you had alluded to it a little bit earlier, of getting things more refined with the actual implementation of the treatment. So what's on the horizon here coming up in the future for Neuromod and the Lenire device?
Yeah, so that's the part that I get very excited about, and I know a lot of folks who have talked to me, and also I've seen some of those blogs and so forth too. It's not necessarily going to work for everyone, right? And you have to kind of think about why that may be. And I don't have perfect confirmation of the mechanism of action, but I feel strongly about it because it makes sense to me. And that's this concept which I explained to you earlier. You've got your tinnitus, and it could be a tonal type of tinnitus. It could be more noise-like, but energies heavily in some range. And you basically stimulate sounds and reinforce that try to shift your brain away from that. In this approach here, we've done a good job at trying to create a lot of sounds that, for most people, we would believe, has sounds that are predominantly not your tinnitus, right? That's the idea. But you can imagine in the future, and we still got to figure out how this can be done efficiently, is you could find a way to better match your tinnitus and then create sounds that are customized to each individual, right? And it may be that those individuals who are not benefiting, right, from Lenire is because the sounds they're presenting are actually not ideal for their tinnitus, right? And it could be even coinciding with their tinnitus sounds, and that's where you may have some exacerbation, or fluctuations of the tinnitus situation. So that's why I do think that's the future, right? And how we implement that and how we make it efficient and customized, I think we'll get there, because with all kind of the big data and AI, algorithms, you'll be able to start to do it in an efficient way.
Well, that's exciting. I'm looking forward to all of this as it continues to kind of unravel, and as we learn more about this, and is really looking forward to the 10A3 publication that will be coming out in a scientific journal. I'm not really sure which one. I don't know if you know or if you can say, but regardless, and then also seeing the clinical data from different clinics that are out there. Emily's clinic, Jason's clinic, and all of them, to see kind of what we see there with actual like boots on the ground treating patients in a clinical setting. I think that'll be exciting. But thank you so much for joining me on the show today. It's been a pleasure chatting with you. I'm sure this won't be the last time that we talk, but guys, if you enjoyed today's episode, make sure that you hit that like button, and if you're not yet subscribed to the channel, go ahead and hit that subscribe button, and we'll see you next time.